Outlines. Outline for photomolding, outline for impression, same outline for finer denture. There are very specific outline form required for removable prosthodontics. Please take a look at carefully about this mandibular maxillary denture. At the end of the session, I'm going to show you same picture again and see whether you be able to identify which outline form was incorrectly formed in this particular case. When it comes to the outline, this applies to photomolding procedure and the final impression. You are expecting the same outline form while you are making photomolding and final impression. Eventually, this outline form will be represented in the final restoration. This example of picture showing when you have a correct outline form for both maxilla and the mandible. So let's take a look at the basic requirement of impression making. You need to know about the oral anatomy and also a basic and reliable technique that you need to use when you're taking the impression. You also need to understand about the material that you're going to use during the impression taking. And of course, you need to learn the skill of impression taking. And the last, patient management, also important for good impression making. One of the classic articles discuss about fundamental rules for making denture impression was published in 1951 by Dr. Roland Fisher. He made 6 rules. The first one, Rule 1, radiographically, visually, and digitally examine the oral cavity. So basically, you are looking for an examination carefully about the existing condition before you start the treatment. The second rule is surgically remove such abnormal formation as would prevent successful completion of impression. For example, patient has abnormal structure, abnormal pathology. You need to surgically remove first before you taking the completion of impression. The third rule is obtaining the required extension outline. We're going to discuss Rule 3 more in depth and detail. Rule 4, locate and provide for area of variable tissue displaceability. Particularly Rule 4 are for the maxillary impression taking. Rule 3 is meant for mandibular impression taking. In Rule 5, obtain the required retention outline form. And Rule 6, obtaining required adaptation form. So these 6 rules is required for the ideal impression making. And as I mentioned, let's take a look at the Rule 3 more detail, in depth. This rule pertains particularly to the lower impression. In cavity preparation, we are all aware there's acceptable extension outline form. There is acceptable extension outline form for lower impression, and is equally as consistent as a cavity outline form, meaning there are very specific outline form that you need to look into. It is consistent, and consistent because it's always governed by the same structure, and these structures are in the same position in every case, and they function in the same manner in every case. So mandibular structure, pear-shaped pad, buccal shell, muscle attachment. Let's take a look at the pear-shaped pad. The term was coined by Craddock and referred to the area formed by residual scar of third molar and the retromolar pad. It's right in this lesion. Mucosa of the pad usually attached to gingiva, which is firm, stipple, and has a dull appearance. So this is area that we are called the pear-shaped pad, and one of the most important landmark for the mandibular anatomy. This pear-shaped pad is bounded posteriorly by the temporalis tendon and laterally by buccinator and medially by pterygomandibular laphae and superior constrictor. So it's all surrounded by these tendons and muscle attachment surrounded. The reason this pad is so important for support is that this an area rarely resolve. This area, no matter even though the alveolar ridges continuously resolve after teeth loss, this pear-shaped pad doesn't change the form and doesn't get resolved. And it's very important because that's the consistent position landmark. Therefore, we use as a most important reference point when you fabricate the denture. The next one is M-plane. The anterior border of the masseter muscle will always be founded to extend anterior to the soft retromolar pad on the mandible, and consequently will be the determining factor in the distal buccal extension outline of lower denture. And this circle red side on this is the pear-shaped pad, and this is the shape. This is the shape called M-plane. This shape of M-plane will be affected by the masseter muscle activity. So this shape, the red mark, are the area of masseter muscle attachment directly attached to the side, which is M-plane side, and depends on the muscle activity. When its muscle activity is strong, it will be concave shape because it's pulling a lot of muscle fiber, and medium will be straight shape. And when this masseter muscle activity are weak, then the shape could be convex. So when it's again the red sign when the masseter muscle activity are very strong, the blue color will be when it's medium activity, and the yellow color shows when it's weak masseter muscle activity. So it depends on the masseter muscle activity, the shape of M-plane will vary, depends. This is one of my favorite casts that show very obviously about the muscle activity, which is M-plane shape. And you won't get this kind of impression consistently because to be able to have a masseter muscle contract, the patient has to bite hard when actually impression is taken. So it is not common to getting this shape on the impression. Although, as you can see, this very well contoured M-plane shape, which is concave. So this one is showing very concave M-plane shape. And this is another view. There is a pear-shaped pad, and then buccal to distal of the pear-shaped pad. This is called M-plane, and this particular case showing concave M-plane contour. When your prosthesis violate this M-plane and it causes a sore spot or discomfort to the patient. So when you look, this patient came in complaining about the pain only when the patient biting hard. So when the normal wearing patient is comfortable, but patient complain when they eat hard food, that's the time patient feel discomfort inside of their patient mouth. When you look into the intraoral condition carefully, you could identify the red indentation mark on the end plane area. It caused by overextended removable prosthesis showing on this picture. So the solution is this convex shape of mandibular distal buccal corner should be trimmed to accommodate strong master muscle activity. Is called end plane space. So correct shape is drawn on the the black line, and again on this both side, patient right side also showing red sign due to the overextended denture border. And so that how we fix this end plane overly extended, instead of having the convex shape, we shape it from convex to this particular patient. We made a straight end plane outline form, which solved the patient main problem. So again, end plane is a determining factor of distal buccal corner of mandibular prosthesis. The next outline is called B curve. Between the distal attachment of the buccinator muscle on the mandible and the anterior border of the masseter muscle is a triangular free space, the buccal pouch, permitting a large stress-bearing area to the lower base at this point, quite commonly known as buccal shelf. This is to designate the B curve and represent the buccal pouch, an area which permit the extension of denture base further buccally. So in this particular outline, we're discussing right next to the end plane. And when you look into this clinical picture, this is the end plane, and this is we call B plane or buccal shelf, another name of this area. This external oblique line and crest of the alveolar, which form the boundary of the buccal shelf. Buccal shelf is a primary support area because it is parallel to occlusal plane and is relatively resistant to resorption due to the dense cortical nature of the bone. So this buccal shelf or B curve are primary stress-bearing area of mandibular denture. The next outline is called B plane and I plane. The region of mandibular anterior to the buccal pouch or B curve is the principal attachment of the buccinator muscle and is referred to as a B plane, which is shown on this color range. From the C curve, which is buccal frenum attachment, or C curve or cuspid eminence, to the median line is called I plane. So called because it is reached formed by the loss of incisor teeth. And these next to the planes, there are muscle attachment, and it's called the buccal attached frenum. It's in between this B and I plane. And of course, in this picture, it's also shown the lingual frenum is showing on the picture. So B plane and I plane, it was discussed, and that will determine the contour of removal prosthesis. The next one is F plane. The lingual periphery starting at the median line and proceeding distally. Present the first a long plane extending to the second molar lesion, which has been designated the F plane. F means for floor of the mouth. And also it's called the lingual vestibule, lingual outline form of mandibular denture. So it starts from the lingual frenum area. So make sure you do provide the lingual frenum space and extend to the distally to forming the F plane or lingual outline form. And the last outline form is called PG curve. Finally, a curve extended distally, then upward from the lingual border at the third molar region. This has been named the PG curve after palatoglossus muscle, which function in this area. So in this picture is showing the red signing of PG curve. Along with the outline of mandibular denture, you also need to look at the muscle attachment around this outline. Floor of the mouth, it determines the functional depth of alveolo-lingual sulcus. You need to check how deep is this mylohyoid space by putting the mirror into this space. After placing the mirror in the retromylohyoid space, instruct the patient to move the tongue to the opposite side. The less your mirror is displaced, the more favorable the floor of the mouth posture, and the longer the distal lingual flange will be located in this particular lesion. So we just review outline of mandibular impression, and it was in rule 3, and these are the outlines that you need to look into when you're taking mandibular impression, including photomolding and final outline form of your complete denture. This is another view with the impression itself, and it shows all the outline that we just discussed in this picture also. Additional information about the muscle attachment are tongue position. Especially for the mandibular denture, the tongue position are heavily affect the stability and retention of a complete denture. When you look at the left side, this is a favorable position of the tongue for the mandibular denture. And when the tongue are retruded, it's called the retruded tongue position for the mandible. These are very poor or unfavorable condition of mandibular stability and the retention. When you complete the border molding and do have good outline form, that will determine the retention of mandibular denture. It doesn't have any suction effect or retention. when you have properly bottom molded, you could hear the suction effect. So let's go back to the rule 4, locate and provide for area of variable tissue displaceability. This rule 4 apply for maxillary impression taking. The first posterior border of the upper impression area, the posterior dam area, this tissue extending from the hemular notch on one side to the other hemular notch. It is possible, in fact advisable, to extend the posterior dam area of impression over the proximity of posterior palatine foramens. So there are two palatini foveae located on the back of the palate, and your impression always should include this palatini foveae and extend it furthermore. For maxillary structure, there are frenums, posterior palatal limit, and denture-bearing surface need to be discussed. Of course, frenum are the folds of mucous membrane containing fibrous connective tissue, and frenums are of little consequence. However, they may limit denture extension or make seal difficult to maintain and occasionally affect the retention of maxillary denture. For example, this prominent frenum should be represented on the final denture prosthesis, allow having the frenum freely move. Posterior palatal limit, in particular region of maxilla, the presence of these glands permits compression of the tissue, helping to overcome poor adaptation of denture in this particular posterior area, secondary to the shrinkage of acrylic resin during processing. Peripheral seal of the denture is thereby maintained when you compress this posterior palatal limit. So in this particular area, which is salivary gland are underneath, and these are the area that you want to completely seal with your final prosthesis. Again, this posterior palatal limit is shown on the red color of this picture on the impression. The hemular notches are quite different and varied among the patient. This one is a shallow hemular notch, and these are very deep hemular notch area. It's very important to complete closure of this anatomical structure to have optimum retention of maxilla. Without having any compression on this posterior limit versus having compression on this particular area, the retention value will be double when you're having posterior palatal seal. So it's very important to have proper seal of this posterior palatal limit. This line will have two particular anatomy. Pterygomaxillary notch is called hemular notch, and this between the tuberosity of maxilla and the hemulus of medial pterygoid plate. And right, this slight indentation called the pterygomandibular laphe, and palatini foveae, which is indentation near the midline of palate formed by coalescence of several mucous ducts, and which is located in this particular picture. And this should be covered during the impression taking. And another important factor, outline. The next area to be considered is the median suture of maxillary bone. The next area to be considered is the region of incisive foramen. Through this foramen emerge the nasopalatine nerve and the blood vessels coming out. So we just discussed about the outline of maxillary impression, starting from posterior palatal limit and frenulum attachment and displaceable tissue located on the posterior limit and incisive papilla. And on this particular impression should have outline of maxilla that we just discussed. From hamular notch, Lafay, Partini foveae, and buccal vestibule, and frenulum attachment, and anterior incisive papilla area. So we discussed about outlines required for the good impression for mandible and the maxilla. And please take a look at this picture again that I show you at the beginning of this outline form. Now you should be able to see which outline form are missing or incorrectly registered in this particular prosthesis.